He came for
worked up for an elective surgery. But when you're presenting a case, how would it, when that
Yeah,
you start with that?
in clinical medicine, we are all taught from decades that you should start with this patient has come with the following chief complaints 1, 2, 3, so many years or months, so many years or months in chronological order. Then elaborate the first symptom, second symptom, third symptom, any negative points and positive points, then past history, like that. These steps cannot be overruled. Sometimes, rarely we do get cases of murmur detected in unrelated illness or school health checkup. That time also, what you are supposed to tell is in what clinical circumstances that was detected. Then you have to elicit by leading questions if any symptoms are there or not. Especially in children, that happens. You have to ask how he is performing in the school as compared to others, not in the studies, in playground, in climbing stairs, in taking part in activities. You should probe there by leading question and find out. Then from parents, you have to find out whether there was any proper weight gain or not. Then they will become the chief complaints, like failure to gain weight, like that. You have to elicit, especially in pediatric cases. There, adults, rarely we get a case which was routinely detected or unrelated illness you detect. Like that, that is the approach, right?
understood. Yeah.
Any discipline, you are not wrong. The final thing you will say that finally this patient has come to this place and has been scheduled for a definitive surgery. That should be your last sentence. It should not be that she has now come for a planned definitive surgery and then you go ahead. It's like I come to your hospital and you are showing me a case. So, okay, you said, sir, this case has come for XYZ surgery. It's not like that. Here you have to build it up, as Professor Patnaik sir said.
So he presented with the chief complaint.
Just keep to your basics. What you learned during your MBBS and MD days. Always start with the basic data, presenting complaints, history of present illness. Do not depart from this. You don't have any advantage doing this.
Okay, restart.
Yes, sir. I told you about the female adolescent girl. She is coming from Darjeeling, West Bengal state, studying 7th standard currently. She presented with the chief complaints of recurrent LRDI, recurrent respiratory tract infection since infant's period, and a history of exertional dyspnea since childhood days. When she became active, then history of spotting episodes since for last 3 years. So history gone back to newborn period. At 3rd day, baby had a fever for which baby evaluated and diagnosed as a congenital heart disease. They are advised to go for surgery as soon as once she got adequate weight gain. After the patient got discharged, in around 3rd to 4th week, patient developed severe respiratory distress as noticed by mother, evidence of increased intercostal retraction and also associated with fever. But there is no feeding difficulty, there is no suckers and suck cycle, there is no forward sorting. For which patient got admitted again and stabilized and discharged and advised to go for a follow-up surgery once she got an adequate weight gain. However, in between patient, after that patient asymptomatic since 1 year of her age, then she developed a similar kind of episode. For that same, she got stabilized and advised to go for surgery. That time she achieved 5 kg, but due to financial constraints, she not able to underwent surgery. After which, during childhood days, patient used to get that relative episodes were frequent, which is around 3 to 4 episodes per year, which is not associated with hemoptysis. That the LRT episodes present till now. The last episode was just 2 weeks back. Compared to initial childhood days, now the LRT frequency is reduced compared to that time. Then after that, during childhood days, she developed exertional dyspnea, which is insidious onset, which is class 2 according to Perloff grading, for the last 8 years, he's having the dyspnea. The dyspnea is not associated with the paroxysmal nocturnal dyspnea or orthopnea. There is a history of squatting episodes present for the last 4 years. And there is no history of palpitation, no history of syncope. There is no history of chest pain. This patient. After severe exertion, he used to go the knee chest position, sir, after the severe exertion to get rid of the exertion. The squatting episode in this case quite unnatural, sir, because squatting episode commonly occurs around 3 to 5 years during the toddler period. Now in this case, our case, which is developed around 8 years of her age, around 7 to 8 years of her age, quite unnatural.
See, two things don't add up. One is repeated respiratory infection and squatting are indicating two different pathologies. Squatting episodes are characteristic of reduced cyanosis with
Squatting indicates
pulmonary blood
reduced pulmonary blood flow.
Usually those entities may have squatting.
And LRT, frequent LRT indicates increased pulmonary blood flow.
Yeah, so you are
Both are
Usually left to right. Cyanosis also may have this respiratory. Because squatting is there should be emphasis on bluish discoloration, either noticed by parents or the first doctor who has seen has brought to their notice that there is bluish discoloration. So in this, whatever you said, you should again do small medical editing. Say that the parents were brought to the notice of existence of some heart disease when they went for this episode. Then onwards, they were observing like this. You can tell that way actually.
And the other thing I would like to add here is you brought about squatting. All this while you, as Professor Patnaik was telling, you fed us with the idea that it was primarily a recurrent respiratory tract infection. Now, when suddenly you want to present to us that is squatting, which is like totally opposite direction, is it that it is that the child gets a sense of fatigue and just is taking a rest? Squatting is a
No,
different.
I actually
That is, it's a different issue.
I put a leading question, sir. The moment patient also now it is 12 years. He's telling purposely after the severe exertion or something, he used to get severe fatigue and dyspnea. He used to get the typical knee chest position.
Fatigue and dyspnea, that's a different issue, sir. Fatigue and dyspnea, you said knee chest. When you say knee chest means squatting and knee chest means it means something, it carries a totally different connotation to the people who are listening to you. I get fatigue or I get dyspnea, I sit down. That doesn't mean that it's a squatting episode. I understand the difference.
But she used to tell in the typical portion. Whenever she, after which but that time during the knee chest position, the parents as well as the baby noticed some bluish discolorations. In old wood series, around 3 to 5%, they will get VSD. PS will get a VSD, PH will get VSD. Yeah, very uncommon. Since that history is significant, I just want to.
Total, you have come to diagnosis also, know the case very well.
See, what the parents are telling is the actual story at the level of their intellect and their experience, their interpretation. That is like raw vegetables. But you are supposed to cook it and give to the examiners in a cooked form. Easily digestible, understandable, it should be assimilated. And it should fit into the final impression what you are having about the medical condition. Ultimately, what history you are telling should not be raw sentences what the parents are using. It should be edited appropriately, and a few things may have to be underplayed, a few things have to be elaborated. For example, whatever you told in that squatting is an important hard symptom. Fluid descalation, you said that is also important. Important. If you are missing it, then it's not tallying with the natural history. And recurrent respiratory infections should also be taken with pinch of salt. Respiratory infections are significant in the early infancy and early toddler age if it is lower respiratory tract infection. Not see, if you see in a house every month they will have upper respiratory infection, many babies, yet they are playful. They don't need any medicine except some paracetamol occasionally. Those are all not counted to be significant symptoms of lower respiratory tract infection. They do not indicate that he has got a left to right shunt lesion. They do not. So there is a definition given by Pediatric Association what is to be taken as significant. In the days of early days, they used to say if any respiratory infection is there, patient is in distress, X-ray is done, there is a patch, or admitted and given IV antibiotics, all these things are there, then you take it as important. Nowadays, there are such beautiful oral antibiotics are there, efficient. So at home also you can treat with even moderately aggressive infections can be treated at home, which previously they were taking as LRTI. Okay. So it should always be taken with pinch of salt, right? And
One
the-
more he used the term Perloff grading. Perloff grading something used.
Since she's, what is Perloff grading, any favorite for us? Same like NIHO classification for adult, here the pediatric age group we use Perloff grading for the classification of Disney functional class. Yes.
Childhood days and everything, what is the age of the child?
So now it's 12, sir, 12 years.
More specific, other than childhood days,
Almost.
still in childhood. Child, specific now and the chronological order you have to tell.
Is there any other important history there?
No, sir.
Okay, what is your diagnosis?
Pulmonary blood flow situation or from the history so far. Blood flow situation or is pulmonary?
According to history, both recurrent relative episodes also is there and squatting episode also is there, but the squatting episode is quite unnatural, quite later. So I want,
Among the two, you don't.
I would like to the history of recurrent relative, which is increased pulmonary blood flow conditions. So I just want to give the less weightage to the squatting episode.
So what is your diagnosis, sir?
Or increased pulmonary blood.
Blood flow with cyanosis.
Sorry, sir.
With
cyanotic or SN.
Only during squatting episodes, after the severe exertion, during squatting episode, the parent were notices, sir. Otherwise, at rest, no cyanosis.
okay. So your clinical diagnosis, the left right shunt at what level? From history.
From history, it can be pre-tricuspid as well as post-tricuspid. In case of pre-tricuspid left to right shunt, left to right shunt, there could be large ASD or associated with pulmonary PAPVC like scimitar-like syndrome. They will have a recurrent relative episode. Scimitar syndromes.
What is
They used
that?
to have a recurrent relative episode.
What is that scimitar syndrome? Scimitar syndrome is a clinical diagnosis from your clinical diagnosis.
History I'm telling, sir. Because
No. History and clinical diagnosis can be scimitar syndrome.
because of recurrent relative episodes in pre-tricuspid shunt, so I just want to include the scimitars. Otherwise,
They're all sir pediatrics.
Nobody
Scimitar-
talks about scimitar in basing on history.
okay, I would like to consider first large post-tricuspid
See,
shunt, sir.
You
Left
are,
to right.
you are expected to take the history and put into the described clinical methods and come to a group diagnosis at least. What is group diagnosis for children? One is acyanotic group or cyanotic group. Again, cyanotic group, reduced pulmonary blood flow or increased blood flow. So at least 3 or any other group like obstructive lesions. Okay.
Yeah.
One of the 4 or 5 groups only it will come. So at the end of history, you will be grossly putting the patient as cyanotic or acyanotic. Acyanotic again, some left to right shunt or some obstructive lesion or regurgitant lesion. So one of the groups it should belong to, right? Other than this, of course, is electrical problems, arrhythmias and all that.
So based on the history, I would like to consider acyanotic congenital heart disease with the left to right shunt with increased pulmonary blood flow.
Means you are putting your group diagnosis as some left to right shunt,
Yes, sir.
okay?
With
Basing on your history.
so, the post tricuspid at the level of ventricular level, like large VSD, at great arteries level, large PDA can be possible with the recurrent LRTA. With the increased blood flow.
Why should they develop cyanosis on exertion? Left to right.
Exertional cyanosis may be due to at this age the possibility of Eisen migratation also can be possible, sir. During exertion, they will get a exertional desaturation as well as cyanosis. Otherwise, some during large VSD, that jet gasolization can be possible as a second DD, and also the frequency of LRTA was reduced compared to initial toddler period. So that will be my second DD for the cyanosis reason with the large left to right shunt. And third might be rather than left to right shunt, I would like to consider some top physiology with some good pulmonary blood flow. During exertion only, patient will have a cyanosis, like spotting episodes. So that also can be possible.
You are telling about cyanotic heart disease, no? Your first group is cyanotic
DD,
heart disease.
yes, sir.
Why top again?
So SAR asked for exertional desaturation reason, cyanosis. For that, I just giving the DD, sir. One is VSD with the Eisen migration, that can be possible. VSD with the gasolization. And third would be some top physiology will have a minimal cyanosis at rest, may go unnoticed. During exertion only, the cyanosis might come because of decreased.
But he has got a history wise, there is increased frequency
yeah.
of a lower respiratory tract infection.
Yes, sir.
Top physiology, you get that.
But at the same time,
Sir,
exertional
what is
cyanosis also is there.
sorry, what is your understanding of top physiology? What is, by using the term top physiology, what is your understanding?
Top physiology will have a reduced pulmonary blood flow.
Then why are you bringing it here? You are telling top physiology like thing with, why are you unnecessarily inviting controversies here? I don't understand.
Dr. Nitin, do you have some idea about TOF may be echo diagnosis, but they are acyanotic at the time of examination. That's given a
Yes, sir.
term known as pink TOF. That means it is so faint that clinical examination may miss the cyanosis. Those varieties are there. So that is there.
So that-
Second, so you should understand that. Second thing is cyanotic heart diseases also can have increased pulmonary blood flow and go into failure. What are those? You give some 4 examples.
Sir, at this age, we can consider like
Age
Generally,
you tell.
sir, generally increased pulmonary blood flow with the cyanotic congenital heart disease will be TGA, TAPVC, truncus arteriosus, and tricuspid atresia, and tossing being anomaly like TGA physiology. So these are the ladies. At this age, we can consider TAPVC might be. Others and all, it won't survive like till this year, very rare. And sometimes TOF with that is a decreased pulmonary flow condition with a collateral SMAP cast that also can be have a similar kind of presentation. They will have a decreased pulmonary blood flow because of MAP, large MAP.
Second diagnosis in mind before exam. At the end of history, what are the 2 diagnoses in your mind you want to consider before going to examination?
So one is a large VSD with the
You tell
gasolization.
1, this one, 2 is this.
One is large VSD with some gasolization developed. Gasolization, RVOT hypertrophy.
You want to say large VST gasolization is number 1 diagnosis.
Number one.
Number 2,
Second one is since patient having that swatting episode also, I would like to consider top physiology with the MAP cause.
of physiology with MAPCAS. Okay. Usually they don't go together. Usually they don't go together. Okay. Anyway, you go to examination.
PhD with severe PH, don't think.
The severe piece because of recurrent LRT episodes are there.
No,
So
third diagnosis, PhD with severe PH.
PAH.
Huh.
But the recurrent LRT episodes are still is there, sir. So that's why, but still can be possible because patient having exertional cyanosis, that also might be third DD, sir. for the cyanosis because of the cyanosis. The VSD with the crystallization, VSD with the Eastern micronization, and top with the large MAPCAs.
No. Top of
These
the
are the
Malpa-
3 TDs.
Yeah, how upon top of the large Mapka gets a repeated respiratory infection?
Because of increased collateral.
Increased collaterals. The increased collaterals from birth.
What is the mechanism of increased respiratory tract infections in VSD? What is the mechanism?
Sir, because of increased pulmonary blood flow.
DD of sinuses to increase pulmonary blood flow. But top of the large amount of Mapka won't give rise to recurrent lower respiratory tract infection.
On examination, patient comfortable, cooperative, no pallor, no interest, no cyanosis, no clubbing, no lymphadenopathy, no pedal edema. On vitals, pulse rate 82 per minute, regular in rhythm, normal volume pulse, no specific character, no radiofemoral delay. Pulse pelted all peripheral vessels, all peripheral blood vessels. Blood pressure 100/70 in both upper limb, and there is a systolic blood pressure of 100 millimeter of mercury in lower limb. JVP is not elevated. Normal waveform. Abdominal reflex is normal. Saturation 98% in all 4 limbs at rest, sir. During exertional, I just look for exertional desaturation. There is no exertional desaturation, sir. It went up to 94. So exertion, yes, sir.
On exertion, there is no desaturation.
94 remember. From 98 it went to 94. From 98 it went to 94. Sir. Inspection and palpation. Just all symmetrical. Trachea appears to be in the trachea in the midline. Apical impulse, which is in left fifth intercostal space at the midclavicular line, is RV type of apical impulse, which is diffuse in nature. There is parasternal impulse is present at there is a systolic thrill present in the second space, left second intercostal space. There is a visible pulsation present in the left second intercostal space. There is no scar, sinus, or dilated veins. Shall I proceed?
Any sound, palpable sounds?
Sounds are palpable? Any
There
sound?
is no palpable sounds, only impulse are there. Parasternal impulse is there, and systolic thrill is there in the second space, and visible palpable as well as visible pulsation is there in the second space.
What do you think from this at this point?
Parasternal heave is there or not there?
Pulsation there.
It is persists less than 50% of the systole, so it's just an impulse.
So no parasternal heave.
There is no parasternal heaves.
So at this point, what do you think?
Sir, from this inspectory and palpatory findings, it is a RV type of apical impulse with the increased volume overload, RV volume overload type of hemodynamic.
Only volume overload.
RV volume overload. Because of why evidence to be
No, no.
parasternal impulse.
Your clinical impression was
RV.
post-tricuspid shunt, isn't it?
RV apex you got it.
Yeah, now RV apex. Sir.
RV apex got a pulmonary area.
I didn't come to auscultation, sir. Only
sorry.
palpation.
Thrill. Got a thrill in the
Thrill
pulmonary
is there, sir.
pulmonary area.
Yes,
And
sir.
RV impulse is there.
RV impulse is there.
And you got RV
Parasternal
apex.
impulse, which is correlating with the sister apex. So most probably RV pulsation, and not due to LA pulsation, and the visible and palpable pulsation in the second space. Pulsation is there. So RV volume overload features is there. RV type of apical impulse with the RV volume overload features are there, sir.
Tell me what could be the cause, no, possible?
RV volume overload condition with a thrill, you tell.
RV volume overload with the thrill.
Which condition you will have a systolic thrill as well as RV volume overload.
Sir, ASD with the PS.
You will get thrill very frequently in ASD.
With the PS.
ASD with the PS, sir.
PS.
No, Lutembecker syndrome.
Huh?
That time also RV volume overload with
Thrill.
thrill.
Okay.
Then patient, if I have a PS and PR, that time also we'll have a RE volume load along with the thrill, PS, PR. But, and
Okay.
Is second space,
sometimes subpulmonic PSD,
second space, percussion second space क्या है?
second space percussion is dull, sir.
Dull. So that is PA dilated there.
Yes, sir.
So at the end of history, diagnosis was post-tricuspid shunt, either VST, maybe PDA also, you didn't tell. Then at the end of your examination, short of auscultation, the diagnosis is AST-PS.
HDPS and
That's what you told, no?
Yes, sir.
and PSPR.
Or PSPR.
PSP or Lutembecker because of thrill as well as RE volume load.
Lutembecker, did
Yes.
you say that?
Lutembecker.
Thrill inspection and palpation, Lutembecker I told, so because of thrill as well as RE volume load.
Okay.
How frequently you get an isolated lesion as PSPR?
That is quite right, sir. That's why
Just
usually
bring a-
post.
Could it come as a combination with some other lesion? You're not entirely wrong. Could it come
Sometimes
features of a PS with severe PR? Could it come in a combination with some other intracardiac lesion?
the top with the option pulmonary valve
Ah,
will have a
Yeah, you can consider, it need not be cyanotic for your kind of information.
percussion, right heart border corresponding to the right sternal border, left heart border corresponding to apex, liver dullness noted at the right fifth intercostal space. Second space is the pulmonary area is dull. Auscultation, S1 normal, S2 is single, S3, sorry, no S3, no S4. There is no additional, there is a non-phasic ejection click is present. Murmur in the medium frequency, sorry, mixed frequency of ejection systolic murmur.
Non-phasic ejection click.
Ejection click is there, sir.
Of what? Outy or pulmonary?
This is pulmonary area I'm considering, so because of in inspection and palpation, you get a increased pulmonary blood flow condition.
Non-phasic you're telling, non-phasic you're telling, no? Non-phasic. Non-phasic pulmonary click in pulmonary area.
This is a, I am considering is a vascular click, sir, which is non-phasic.
It is a vascular click.
A vascular click I'm considering rather than valvular click.
Non-phasic vascular click. I mean, pulmonary click. Pulmonary ejection click,
Yeah,
non-phasic.
yes, sir. Yes, sir. Pulmonary ejection click of vascular type. There is a mixed frequency ejection systolic murmur, which is grade 4/6 at the pulmonary area, which is
Describe the
P
murmur.
is-
Describe the murmur. Now,
there is a mixed frequency of grade 4/6 ejection systolic murmur present at pulmonary area, which with the
no, it is what?
Mid to late.
Picking on the murmur.
mid to late peak, sir.
Mid to late.
Not yearly peak, mid to late peak. There is another murmur of high frequency yearly diastolic murmur of grade 3/4, which is present at same pulmonary area.
High frequency. Got high frequency.
Yes, sir. Both murmur high frequency, sir.
Both high frequency.
Actually, first one is medium frequency.
Second one high frequency.
High frequency. Actually, both are getting in the same space, sir. With the clear in between S2, I'm hearing. So this is not a continuous murmur, I feel. So I would like to consider this like a to and fro type of murmur because it is. I'm considering it's a single side murmur, and the character of the murmur is quite loud murmur.
Which murmur correct? History diastole. Both are louder. Both are loud.
Sir, compared to diastole, systole is loud, sir.
Okay.
Other system examination is normal.
Okay. What diagnosis?
Sir, my final diagnosis is situs arteritis levocardia, cyanotic congenital heart disease.
Cyanotic. You tell 98%, 94% cyanotic.
Sorry, sir. Acyanotic congenital heart disease with increased pulmonary blood flow condition I would like to consider off with the absent pulmonary valve.
Increase pulmonary blood flow constant, top with absent pulmonary valve.
Of the pulmonary valve is cyanotic or cyanotic?
Cyanotic.
Okay, depends. Sometimes also acyanotic also. Fine, usually cyanotic, mostly cyanotic, but could be acyanotic. Then, but absent pulmonary, we are getting click, no? We are getting click, how can valve be absent?
Click, vascular click or not valvular clicks.
Either no valve, you can't get a vascular click also.
Then might be due to aortic click, sir. Because
Huh?
of aortic. Yes, sir. Good flow. Yeah, yes. Right back.
If not, if not valve not there, neither you get vascular click nor the valvular click. But that is, I think taking rest to get relief of dyspnea. Just taking rest, not spotting.
What I mean to say, unnecessarily figuratively, you state it and then you invite trouble for yourself.
He modified that. He took
Ah.
rest, some sort of rest.
So now you said cough, absent pulmonary valve.
Because of that, after the auscultation, till the auscultation, I'm not considering that, sir. After the auscultation, because of the typical murmur character, so I would like to consider that.
So what kind of murmur EDM will get here? You actually not EDM. In fact, not EDM.
No, what is the typical murmur in absent pulmonary valve syndrome?
There's a to and fro murmur. The character will be like a saw-wood murmur they used to.
But Dashley murmur is what? Dashley murmur what? A high pitch or a medium pitch, a low pitch? High pitch murmur, where is gradient? Pulmonary artery pressure कितना होगा इधर? How much pulmonary artery pressure here? What could the pulmonary artery pressure here?
AR murmur is high pitched or low pitched?
High
High-
frequency, yes, sir.
This PR murmur?
The mechanism or the pressure differences across pulmonary valve is not like that.
Okay.
In absent pulmonary valve, you will not get similar murmur. Like AR, you will not get. You will get a different murmur.
Medium pitch, medium to low pitch murmur. Understand? So because PA pressure कितना होगा? PA pressure 20/12. No, action 20/12. PA pressure.
PA.
So RVDP कितना होगा? Here. RVDP is greater than PA Dashley pressure or lesser than Dashley pressure? Right one,
Normally, sir.
right one end Dashley pressure. Right hand.
In
Under pressure, sir is asking, PA diastole is 12 millimeter of mercury. What will be the RV diastolic pressure? Sir is asking, will it be same, more or less?
normally or
No, no, in this case,
I couldn't get up.
Pulmonary. Well,
Okay, sir.
Expective.
you want equal or more or less?
More, na, sir.
Left ventricle end Dashley pressure. AR.
More, sir. High.
No, listen.
Chronic AR,
Chronic air is 130/40. How much expected LV end Dashley pressure? Higher or low?
Chronic compensated AR, LVDP will be maintained, not high, sir.
Not raised.
Not high. Only in acute AR, it will go high. The chronic
Higher
compensated
higher
AR,
than the Dashley pressure. Higher than the outer Dashley pressure.
no, sir.
Equalize. Equalize.
End diastole.
Okay.
Sir is asking in this particular case which you are examining, he gives a figure, 25/12 is the pulmonary artery pressure. He just asked what do you expect the,
It will be equal.
I said,
It will be equal.
Nitin, no, what is the Nitin?
Nishant, sir.
Huh?
Nishant.
Nishan. What is the RV pressure here? What is the RV systolic pressure here?
RV systolic pressure is how much here in this case?
It will be equal to LV systemic.
Dashley pressure? RV Dashley?
It will be equal to aortic diastolic. Sorry, pulmonary artery diastolic.
Equal. Well, the blood won't flow from pulmonary artery to RV.
The end diastolic will be high.
It will be less. Not very high. 6, 7, suppose 6, 7. So here 12, 8, 6, 7, gradient is very less. You don't get high pitch.
Okay, your diagnosis is TOF absent pulmonary valve syndrome variant is the diagnosis based on your how you can differentiate it from classical TOF, how you can differentiate it from classical pulmonary valve stenosis with no VSD. One is pulmonary valve stenosis, no VSD.
Okay, sir.
Another is TOF, classical TOF. No.
Okay, sir. First, I would like to differentiate between TOF and TOF with absent pulmonary valve, sir. Case of TOF with absent TOF, the onset of cyanotic pulse and squatting episodes and all will be in after the 2 to 3 months, sir.
Clinical tell.
In TOF with absent pulmonary valve, there will be a typical history of neonatal severe respiratory distress will be there because of absent pulmonary valve. The pulmonary valve will be huge, large PA, massively dilated PA and branch PAs. It will compress the airways, so it will give the respiratory distress. Based on the history, it will give a clue for TOF with absent pulmonary valve. Coming to the examination, in case of TOF with absent pulmonary valve, usual TOF will be like there will be no thrill, but here the thrill will be there. Then TOF with absent pulmonary will have a prominent LA pulsation, second space pulsation because of torrential pulmonary blood flow. In TOF, we won't get that click, thrill as well as the pulsation and all, PA pulsation and all. Then there will be murmur. Coming to the auscultation, the murmur in the TOF only we will get a ESM murmur, sir. Here we will get a to and fro sound murmur. So this is for and TOF with second will be PS with isolated PS without intact ventricular septum, without VSD. They will have a prominent parasternal heave allowing it to prominent A wave and RV pulsation. Basically, it is RV systemic RV pressure overload condition. So we'll have the RV pressure overload features like RV parasternal heave and soft P2. P2 will be delayed and ESM with only ESM murmur will get and with the late peak.
Anyway, in actual
Click.
A click will be there.
Where will you click?
In pulmonary stenosis, we'll give a valvular type of click, which is
Describe that. Describe the click. Describe the pulmonary click in pulmonary stenosis.
which is a basic type basic click, which is present in the second phase, as well as in
yeah,
Okay.
it's actually TOF with absent pulmonary valve syndrome is difficult to diagnose. It is suspected when there is a history which is suggestive of something like a left to right shunt in early childhood, but later it is just like your TOF presentation. But the typical squatting you told is not correct. At this age, it's not expected to be there. It is something equivalent to easy fatigue or something. Okay.
The corresponding to and from murmur.
One thing I want to ask whether this till this age also
Much more closer differential is TOF with severe PR, sometimes associated with PR if it's there, without absence. Means valve is okay, but still there is PR if
with
it
any
is associated.
complicated infected endocarditis something, sir, or few isolated. Dilated.
Dilated. Not dilated.
Actually, without any surgery or without any infected endocarditis, AR is common, tough, but
Why
PR,
correct? Why not in this case BH top with the air?
PhD,
Top with the air, why not?
Yeah, TOF with AR can be confused.
yes, sir.
Why not top with the air here?
Top with AR, I have a RV type of epic impulse, sir. In top with the AR, we'll have a LV type because of AR. And one more thing, history also is not suggesting for AR.
Supposing
And the murmur is,
listen, suppose the patient has 70% overriding.
sorry, sir.
70%
overriding of the outer, 70%.
If there is more overriding, the AR itself will be like PR actually.
That time it can be. We can't, clinically we can't define.
Not pressure. White pulse pressure.
Yeah, sir. There is no white pulse.
No, very typical depends on the high pressure EDM. Low pressure.
EDM.
It's not.
It is not a continuous murmur.
There is a
I'm
gap in,
saying it is a continuum.
I can make out that in between the S2, there's a gap, sir. I can hear the S2 clearly, the pulmonary area also. So that's why I didn't consider of continuous one.
You can say that there is a distinct gap between second heart sound and the beginning of diastolic murmur. If that gap is very clear to your ears,
It's not a
convincingly it is there, then it is to and fro murmur, not continuous. Continuous murmur by definition means it marches over
It will mask
second
the
heart sound and ends anywhere in diastole,
Diastole.
maybe early, mid, or a little late. X-ray, X-ray, I think is more, should be more interesting.
normal 12 standard is ECG. Sinus rhythm. Heart rate around regular rhythm. The heart, sorry, there is a regularly irregular rhythm. There is one premature atrial ectopics is present after that. It is a fourth beat.
Where, which beat?
That fourth beat, I thought it is
Fourth beat, your it.
that
Ah,
fourth
okay.
one. So maybe I feel it is there is a, I mean, the ECG machine ends there, sir. That's why I feel it is here. It is a long. I mean, the RR interval is prolonged.
Last channel.
Rhythm strip is there in 2 and V5 is there. on
Yeah,
the-
yes, sir.
What is that? What is there?
So in rhythm strip there is no ectopics. It's a regular rhythm only.
It is the same, no, it will, same beats only will be taken here.
Sir, actually here that some interrupted is there, sir. Interruption. Yes, sir. Here in
RR is varying. RR is varying, no, so what is it?
Yes, sir.
12-year-old girl,
the sinus arrhythmia.
what is the axis, QRS axis? Is the PR prolonged?
Sir, PR around 200 milliseconds, sir.
It is on the upper limit.
Yes, sir.
Okay, what is the
The
QRS?
axis is right axis deviation around plus 120, sir. Plus 120.
What about the V1, V2? V1 and V2, what
Sorry.
is there?
There is a V1, there is a QR pattern is there, sir. Along with the
QR.
sudden transition is there, V1 to V1 to V2. And
So expect a QR and V1 here. Small R is there, no? You don't
Yes, sir.
expect here, yeah.
yeah, small R is there, sir.
Yeah. Yeah, it is RS.
RSR dash pattern. With the sudden transition in the V1 and V2. There is no
Is it consistent? with
QO
your
in the,
diagnosis? Is it consistent with your diagnosis?
yes, sir. Right axis deviation with plus 120, around 120 degree. Along with the sudden transition is there. The deep S in the V5 and V6.
Why there is sudden transition in TOF?
Because of that, in top of the malaligned septum, where we have placed that ECG lead, so it will pick up the. It won't pick up over there the ventricular septal defect, sir.
Yeah, you have some concept, but the way you are expressing is not clear.
So when we put the lead over the that malaligned septum part, so it will won't pick up the electrical potential of the particular septum.
Something like a electrical window there. Yeah, that's why.
There is incomplete RVB there. Incomplete RVB.
Yes, sir. RVB, incomplete RVB.
Go to the X-ray.
Yeah. The same case, even if you present as TOF with AR, probably you can stand. But
Only
without-
RV impulse.
you can still stand. AR may not always produce,
Okay.
depending on the override, how
Okay,
much
sir.
override.
Yeah. go ahead.
So this X-ray, PA view, overexposed and well centralized, Uh,
Top with absent pulmonary, what will be the typical X-ray?
there will be massive PA dilatation will be there along with even branch, sometimes branch PAs also. And increased blood flow control. Apply plethora will be there.
But this pattern is, which,
Here the PA dilatation,
how is it then?
Some period dilatation,
yes, not aneurysmal, just a PA dilatation is there. There is no aortic evidence of no aortic dilatation. There is no
How
cardiomegaly.
much outliers, which left, right?
Right side aortic arch. Indentation on the side.
How to decide?
Sorry, left side aortic.
How to decide?
Based upon the bronchus crossing, actually we have in the X-ray we have to see the indentation, tracheal indentation.
Indentation on the tracheal wall.
Yes, sir.
Very arrange,
Then here, left side.
listen, RB is volume overloaded. Arrange, there no area at all. Cyanotic heart disease, RA border is flat. What are the possible? Cyanotic heart disease, RA border is flat.
Right heart.
Cyanotic heart disease, RA border is flat in tricuspid atresia.
Okay.
Now, what is that condition? What is that condition? Okay, tricuspid atresia, they are fine. Then, RA no. Juxtaposition of the
Appendage.
So first diagnosis should be corrected by transposition
Yes,
DRV. Conditional case juxtaposition of the appendage.
Echo.
Okay, go to the echo.
Situs artus. Normal draining of IVC into the RA. Cycle. The levocardia. Apex towards the left side, levocardia. This is parasternal long axis. We showing there is a large interventricular ventricular septal defect is there with the overreading of aorta. Is around 50%. Then there is a aortomitral continuity is still present, preserved. So most likely, next slide. There is a RV in normally parasternal long axis view. You're not able to see this much RV cavity. So I mean, considering some RV features of RV dilatation is there. I want to see in further views. Next slide, please.
Are we dilatation or are we hypertrophy?
RV viewer also appears to be hyper.
Echocardiography, RV dimension is more than normal actually. Yeah.
So here there is a color Doppler across the ventricular septum. So there is a left to right shunt across the ventricular septum. Next. Short axis view, parasternal short axis view, showing at the level of aortic level, showing the large VSD is almost ponoventricular type of VSD from the aortic this end to pulmonary end. Along with the next slide, please. Color. There is a free flow across the color Doppler showing across the parasternal short axis view, free flow across the septal defect. Next slide, please. Here the REOT is dilated. Color. Next. So here they along the REOT, they will measure the gradient. So the PR gradient is which one they have measured first?
Are you surprised? Are you surprised by the systolic gradient?
This is
Which one they have measured first?
sir here, yeah, waveform MC.
Systolic gradient, are you surprised?
Sir?
Are you surprised by the systolic gradient? There is a gradient in systole. Are you surprised or is it usual or unusual?
This case, is it unusual or is it
Is it expected or unexpectedly?
Sir, quite, I mean, this much gradient is unexpected.
Unexpected.
Some,
See,
The blood pressure was.
absent pulmonary wall syndrome,
we'll have
and
some,
analysis is usually smaller.
yes, sir, they will have some kind of,
You
you
will
know,
get a systolic gradient.
Okay.
You do get.
pH.
What is the PA pressure basing on this? Can you estimate?
PA pressure from this tracing. PA mean
Sir,
is
this is
what?
PR, peak PR gradient will give the mean pressure, sir, mean PA pressure. So
And diastolic will give.
endosol will give the diastolic PADP, pulmonary artery diastolic pressure it will give. Pulmonary artery diastolic pressure is around 2 meter per second, sir.
He is showing meters per second.
So peak is around 3.5. Yes, sir. Mean is 30, peak is around 16 to 15 to 20.
That is of, what is the size of the pulmonary artery?
They must have measured.
So the size is measured. That grossly dilated. Adequately sized. For management, you have to see the size of the.
Yes, sir.
I think it's that.
Yeah. At least compared to aorta, how much to see?
What all things will you look in an echo when you plan a case for an RVT obstruction like this for surgery?
Sir, we have to see the level of obstruction, and PA anatomy is important. Like Mengun index and Nakata index and all, we have to calculate according to the body surface area, and pulmonary artery branch PA size, and how the arborization and all is difficult in echo. We have to see in the how is the
Any
status
other
of
thing will you see? Do you look in the echo?
echo arborization.
Any other thing? Coronary is.
Yes, sir.
Coronary
Coronary,
is it important?
yes, sir. Coronary is also is important because during planning for surgery, we have to depend upon, I mean, whether to, if abnormal coronary anomalies is there, we have to change the plan of mode of surgery. Extra RVPA conduit and all may be necessary. RVOT crossing coronary is there. And
So how many do you have multiple VHD or single VHD?
yes, sir. Multiple other any
Oh.
associated VSD and all.
How to
can-
see that?
And only thing is,
Only thing is what? Only thing is,
most of the information we can get from echo. The need of cath will be the cardiac catheterization in these top cases now will be for to assess the significant collateral is there. Hemodynamic of the collaterals only necessary. Otherwise, all most of the findings we
Why
can.
can
CT?
you can go per CT
CT
scan,
angio?
no?
CT angio?
Yes, CT angio also. But hemodynamic pressure tracing.
For pulmonary anatomy and all CT is very good.
Very good.
Yes, sir.
Okay.
Anyway, initially your history and defending use of the term squatting was not at all appropriate. History presentation should be more clear, smooth flowing. Okay. The same case could have been much better presented, and the physical examination, it's okay. Like, and discussion is also okay. At the end, you have made up for whatever lapses you have done in the beginning. But differential diagnosis discussion is very important. In that top AR comes very close to the differential diagnosis.
To discuss the different diagnosis.